Learn webinar series. We're so glad that you can be here with us today. Our webinar is called Suicide Prevention, Recognize the Signs, Take Action to Save a Life. As with all of our webinars, you can access our slides on our website at www.ctacny.com. At the end of today's presentation, there will be some time for questions, and if you can please fill out the feedback survey when you leave the webinar, we would really appreciate it because we do take your input into consideration for our future webinars. I feel very fortunate to have had the opportunity to work with our presenter today, Dr. Aruna Jha. She's been really amazing to work with, and she's really an expert in this field. She's the founder of the Asian American Suicide Prevention Initiative and is a well-known suicide prevention specialist. She's been active in addressing suicide risk and protective factors nationally and internationally for more than 15 years. Dr. Jha, thank you so much for joining us today and sharing your knowledge with us. We really appreciate it.
Thank you, Kara. Good afternoon, everybody. I'm very happy to be sharing your lunch hour with all of you. I would like to add a couple of points to the introduction that Kara has provided for me. I've been doing suicide prevention work for actually 20+ years. Most of my program development, advocacy, and research efforts have been focused on college students and underrepresented populations, mainly Asian Americans, but also other immigrant groups. My most recent experience in suicide prevention has been with the Veterans Administration, the VA, where I've worked for 3 years as a suicide prevention coordinator. I'm also a master trainer for QPR, a suicide prevention gatekeeper training program. A long list, but there's a reason why I'm telling you all this. What I've learned in all these years in context is that suicide prevention training is best done in a small group, face-to-face format. There are always people in the audience who've had a direct experience with suicide or suicidal behavior. When one can see these individuals and recognize their concerns or distress, one has an opportunity to intervene and help. But today, you're all only listening in over the web. You can hear my voice, but cannot see me. I hope to connect with you and share some information that you will take back to your work and to your lives. So I kept the outline of the presentation deliberately quite simple. And what I want to talk about is the scope of the problem, some beliefs about suicide prevention, what one can and cannot do, risk and protective factors, and address the issue of safety planning. And hopefully then we have some time for Q&A as well. We've got only a very short amount of time, and so this will be a broad overview introducing the main concepts. Hopefully, you will all avail opportunity to get more in-depth training. I'm sure that there are some among the participants who already have a lot of experience in suicide prevention. So I look forward to your comments and questions. The information I will share is brought to you either with the permission of its creator or is available in the public domain. So I'm going to speak a little bit fast, and I know I have an accent, so hopefully you all understand me. The most recent data from the Centers for Disease Control show that there was 38,364 documented suicides in 2010. The last decade has shown a steady rise in suicide rates. Some of this may be attributed to better data collection, to more accounting for suicide deaths. In general, though, suicide data tends to be underreported, not accurately reported, not overreported, but underreported for many, many reasons, some of which are related to social taboos. There is consensus that these rates will continue to rise and are expected to exceed 40,000 this year. Suicide is a national public health problem. This was declared by Surgeon General David Satcher when the suicide prevention movement first started to build momentum and the National Suicide Prevention Strategy was developed. Picture this. The Yankee Stadium has approximately 50,000 seats. 50,000. Now picture 38,346 people seated there. It would be filled almost to capacity. The emphasis on suicide as a public health problem was made to highlight the fact, though, that suicide, like accidents and homicide, is a preventable death. With education and awareness, motor vehicle deaths have reduced significantly in the U.S. We can do the same with suicide. We have a polling question here. Do you know someone who has died by suicide? The answers are yes or no, but I feel very concerned about people in my life. And there's a reason why we put this polling question in. QPR, which is a program that's called Question, Persuade, and Refer, is a suicide prevention gatekeeper training program that is widely disseminated and on the National Registry of Evidence-Based Practices. QPR research shows that for every 25 people trained in QPR, an average of 2 persons will need assistance with referral information, either for themselves or for someone known to them. 1 in every 54 participants reports having lost a blood relative to suicide and may also self-identify and need referral assistance. In my experience, in every suicide prevention training I've done in the past 20 years, there have always been at least 1 or 2 self-identified individuals struggling with suicidal thoughts in themselves or in their loved ones. Today, I want to applaud all the survivors among the participants. I firmly believe that your courage will illuminate your path and the life of countless others. Because suicide is affecting all of us. There is 1 suicide every 13.7 minutes. There are 105 suicides every day. Those, again, from documented evidence. There are many that we don't know of. Over 4,600 young people die by suicide each year. That's at a rate of 1 suicide every 2 hours that we know of. But the interesting thing is that suicide crises typically are short. If we can help a person sustain this crisis and move on, they have a life that is long and beautiful. This is especially true of young people whose view of the future is foreshortened by the thought that everything must be done tomorrow. Young people are known to be impulsive and very now-focused. They can't see beyond the crisis that they're in. In the last 10 years, there has been an increase in the number of suicide completions for very young children, ages 10 to 14, and even younger, ages 7 to 14. The numbers have increased by almost 71%. Suicide is the third leading cause of death in the ages of 15 to 24 years old, and it's the second leading cause of death among college students. It's significant, I think, that among the very young, we've had an estimated 500 suicides in 2009, again from CDC data. I pulled out some statistics for suicides in New York because I was told that most of you are calling in from the neighboring regions. But the reason why I did this slide is just to draw a comparison. So what you see up there is that New York had a suicide rate of 8 per 100,000, which is significantly lower than the states that had the highest rates of suicide: Wyoming, Alaska, Montana, Nevada, New Mexico, and Idaho, where the suicides range from 18.5 to 23.2. Along with New York City, New Jersey and Maryland and the District of Columbia also have suicide rates that are lower than 9 per 100,000. So the question becomes, what is the difference between the East and the West? Because the states with the highest rates were all in the West. To my mind, some things pop up right away. New York and the neighboring areas are urban settings. They have a very high population density. There are high levels of education. There is a strong community infrastructure. There is proximity, if not easy access, at least proximity to hospitals. There are well-trained first response teams. And each one of you, I'm sure, can add some more to that list. But again, in my mind, there is an underlying principle here. And the principle is that of social networks and social infrastructure. Both of these are incredibly important to the prevention of suicide. The more an individual is connected and engaged with and lives within a community setting, with community being not just a social construct, but also a sense of community as in I belong to a group, the less likely the individual is to succumb to suicidal thought. In fact, many, many, many years of research has shown that social connections are probably the most important factor in preventing suicide. The second point I want to make is that suicidal thoughts, like all thoughts, are natural. They're not normal, but they are natural, given the right context. What we can prevent through our connections is someone acting upon these thoughts. Let me know if I'm going too fast, okay? But I'm concerned about the time. In terms of estimates of attempted suicide, these are broad figures again, and they are estimates at best. But what I want to point out here is in the bullet points that for adults, it's 25 suicide attempts for every death by suicide. For the young 15 to 24, it's 100 attempts for every death by suicide. But for people who are 65 and older, it's 4 suicide attempts for every death by suicide. And what that suggests is that as people age, their lethality of attempts rises exponentially. And so if one sees suicidal risk signs in an older adult, those need to be taken very, very seriously. Just as youth suicide risk factors need to be taken seriously too, but older males, and in this country, older white males particularly, tend to use very lethal means in their attempts. And so the outcomes are more often than not fatal. If you recall the slide about New York and the comparison to the Western states, one of the reasons why the states to the West have such high rates of suicide is because there is a widely prevalent gun culture in those states. And so the means being used are very, very lethal. Every year, there are 1 million non-fatal attempts. So one could also say, I know there have been recent media references to suicide epidemics, but there is essentially an injury epidemic of a very large scale that's going on. And at a very pragmatic level, even the non-fatal attempts are costing society a great deal, anywhere from $5,000 to $30,000 per admission. 5 million people living today have attempted suicide at some point in their lives. There are 35 million people who know a close friend or a family member who has tried to kill himself or herself. This is from the American Association on Suicidology, and they very conservatively estimate that for every suicide, there are at least 6 suicide survivors. And that takes into account the immediate family of origin. But we know that when a young person in high school dies by suicide, the suicide survivors can literally go into the hundreds because the young person has interacted with so many other children in school who are vulnerable. For young people, for this reason, we also need to be very concerned about the possibility of copycat suicide attempts. But going back to the conservative numbers, just by 6 per suicide, and a survivor, the previous slide had said, is anyone who has lost someone they love very much, are related to, care about, that has died by suicide, or the very event has impacted you that greatly that you feel the trauma of that act. You may not know the person very well, you may not have known them at all, but given your own life circumstances, if you are affected deeply by that death, then you are also a suicide survivor. But the point I want to make is that it is the courage of these survivors that are accounted for, who have come forward and engaged in community-based prevention and advocacy for suicide prevention, who say that no one should have to suffer the pain that they do, who channel their grief into advocacy, that has built the momentum behind suicide prevention efforts in this country and the world. Survivors report that advocacy has brought them healing. They are a very strong community, and they need to be. We all need to be a very strong community. Survivors also report that engaging in prevention efforts finally gave meaning to an untimely, tragic death that many feel was meaningless. I want to talk for a brief part about irrational belief. That was one of the items on the outline about suicide and suicide prevention. It is very important, I believe, to recognize the irrationality behind these beliefs so that we can do all we can to shatter them, because ultimately they prevent us from taking action. I have taken this material from the VA's SAVE program, SAVE. And I encourage you to reach out to the suicide prevention coordinator at the nearest VA to you, because you may or may not know that SPCs have in their job description outreach and training activities for all communities around them. So they are a great resource, and I encourage you to use them actively. So, in the interest of time, I'll just read it out. Myth: asking about suicide will plant the idea in a person's head. In 20 years of doing this work, the amount of fear that I see, not only among untrained people, but also among professionals, and the belief system that yes, you can plant the suicide idea in someone's head, it baffles me. Because the reality is that asking a person about suicide does not create suicidal thoughts any more than asking about chest pain causes angina. The individual that is struggling with suicidal thoughts already has those thoughts. Not asking about them when you see some signs is a demonstration of a lack of caring. And many people believe that they are actually showing more caring when they ignore the signs. When you ask someone this question, it gives that person the permission to talk about his or her own thoughts and feelings. There are talkers and there are doers. So it's like thundering clouds don't rain, maybe. But the reality is, and there's lots and lots of evidence to support this, that most people who die by suicide have communicated that intent, often verbally, but very often non-verbally. Someone who talks about suicide gives the guide or a clinician an opportunity to intervene. We need to prepare ourselves to actually observe the signs and listen carefully to what people around us are saying. And if we do, we will take note of the fact that they are talking actually about suicidal ideation, intent, sometimes planning. The next myth: if somebody really wants to die by suicide, there is nothing you can do about it. I have encountered this myth very often when I've intervened with groups of veterans. And I bring that up deliberately because all of us have veterans around us. And I hope that you will take note and maybe bust this myth. Because the fact of the matter is that there are many, many, many people who will acknowledge from their past periods of time when they felt vulnerable, contemplated suicide or actually made an attempt, and went on to live again and never, never, ever attempt again. So these are passing thoughts. This is a momentary crisis, and it needs to be addressed as such. There is always a context to suicidal ideas. Sometimes it's situational. Very often, there are underlying treatable disorders. And providing the safety for meaningful, honest communication is the first step towards possibly saving a life. Another myth is towards prevention, that this person couldn't ever think of committing suicide. And there are many, many reasons. I've just put down 4 there. He just made plans for a vacation. She had young children at home. He made a verbal or a written promise. She knows how dearly her family loves her. And all of those are true. All of those are true. But unless we really ask and avail the privilege of entering a person's mind space, again through asking, we're never going to know what the individual is thinking. And I know of at least one incident where all of those factors apply to the individual who did die by suicide. Left behind 2 little children, a very loving husband, you know, highly educated, had a great job, had everything going for her. The reality is that the intent to die can override any rational thinking. No harm or no suicide contracts have been shown to be ineffective from a clinical and a management perspective. A person experiencing suicidal ideation or intent must be taken very seriously and referred to a clinical provider who can further evaluate and assess and help and provide treatment. Please chat with us. Let us know what are the other myths that you may have encountered in your professional practice or in your personal lives. We'd like to know as well, but I'm going to continue, and Kara, tell me if I should not do that, but I'd like to continue to gather those answers, but move on with the next slide.
Okay. That's fine, Aruna. But if you do have anything to add to this, everyone who's listening to the webinar, please chat in the box to the right, and I will collect those myths and bring them to Aruna's attention. Thanks.
So, what are some reasons that people hang on to these beliefs? That's the question I'm asking you. And I want to give you another piece of evidence here that will prompt more thought, hopefully. The QPR Institute and Essential Learning, which is another organization, have been gathering pre-training data for several years. In one survey, they polled participating clinicians. The data reflects only the previous 12 months, so a very short span of time. There were 2,878 respondents, of whom 2,359 answered the question about losing a patient to suicide, to the point being that these are mental health professionals. 1 in 5, 20% of those who responded reported having lost a client to suicide at some time in their career. Of note, 465 reported 1 client suicide, and 34 clinicians lost more than 1. For these 34 clinicians, the number of client suicides ranged from 2 to 15. The bottom line is, and I imagine that there are many in the participant group who are clinicians here. The bottom line is, and this is my bias, that losing a patient to suicide is the most difficult thing to face us all as healthcare providers. It takes courage and fortitude and forbearance to continue to do the work that you all do every single day, even more so after losing someone you have cared for. If you have lost a client to suicide, you are grieving and you're hurt. You need all the support that you can get. Please consider joining the American Association of Suicidology's Clinician Survivor Task Force. You will get a lot of support from the task force members, and they have a email group. I'm going to talk to you now about risk and protective factors. I was asked to talk about these and give simple strategies of what one can do. My estimate here, and forgive me if I'm wrong, is that a lot of this content will be familiar, but maybe framed somewhat differently. We all, in our attempt to just function today, sometimes lean towards black and white thinking. But the fact is that suicide is not a black and white phenomenon. It is multi-determined, and therefore it needs multiple approaches to prevent. Suicide is often described as a perfect storm, where individual vulnerabilities intersect with situational context and prompt thoughts to behaviors that end in self-inflicted death. Yet, we as clinicians and we as survivors try to find the cause for the suicide. Edwin Schneidman, who was the father of suicidology, which is the science of studying suicidal behavior and suicide prevention, wrote about psych ache. Unbearable pain drives one to find a solution to the pain. If the individual were given ways to cope and shared visions of possibilities, of hope, most people would choose to live. Ambivalence is our friend. As clinicians and helpers, we need to tap into the ambivalence. And every patient that I have worked with has demonstrated that. There is a desire to live that is so strong, but underlies all of the despair that comes from the context that the individual is struggling with. We need to work with that ambivalence and draw them towards life. Yet, suicide is a choice, and that is sometimes very, very hard to accept. It is the decedent's choice. Recognizing it for what it is helps us to accept our own limitations, helps us to move on from our own grief, and to find the strength to help the next person make the choice to live as opposed to making the choice to die. There are 7 life-saving events, and these I've got from Dr. Quinnett of the QPR Institute. Each one of them references something that needs to occur to motivate an individual to seek life once more. Detection of suicidal persons, active intervention, alleviation of immediate risk factors, enhancement of protective factors, accompanied referral, not just a phone referral, access to treatment, accurate diagnosis, and aggressive treatment. These principles apply both on a larger scale when we're trying to do community-based interventions, the public health approach, and at the individual level when someone in your office may have invited you into this very sacred space where they share with you their deepest thoughts and their deepest hope to find solutions. So, just skimming over this, and my hope again is that all of this is familiar to most of you. We know that psychiatric illnesses increase the risk for suicide. We've got to do the correct diagnosis. We know that individuals with schizophrenia and depressive disorder tend to have very, very high rates of deaths by suicide. The same goes for bipolar disorder. But underlying all of this, I think, is the comorbidity of substance abuse and hopelessness. So previously I said that we need to build up the resistance factors so that we prevent all of these underlying characteristics from translating into suicide attempts and behavior. So in essence, we have to erect this wall of resistance. And the wall has many, many bricks to it. It could be different for different people. It's access to a counselor or a therapist, a sense of duty in many communities and cultures. Ultimately, what keeps a person alive is this sense of duty to others, that I couldn't do this to my family, I couldn't do this to my loved ones. Good health, we know that sickness, illness, especially in the elderly, prompts them to consider suicide as an option. For the people who are struggling with mental illness, medication compliance becomes a big issue. If they don't take the medication, the antidepressants don't work. Fear of death, fear of shame brought onto the family, any kind of a fear, if it's a deterrent, It's a good thing. And as clinicians, we need to tap into that and actually bring it out into the open because it is a factor that's keeping the individual alive. Marsha Linehan, who's a psychologist out west, she talks about reasons for living. We need to find out what our patients, our friends, our family members' reasons for living are. Job security, job skills, okay, I lost my job today, but I have the skill set, I'll find it tomorrow. It's a reason for hope. Responsibility for children, support of significant others, that's the social network piece, and you all can read this yourself. But underlying this is sobriety, because all of these factors go out the window if you have a substance abuse issue because you've lost your ability to think rationally. Moving on, I'm going to give you the key elements of the gatekeeper intervention that has been rolled out by the VA. So now every VA, if you don't know this, has a team of 2 to 3 suicide prevention coordinators and case managers. And borrowing the term of aggressive treatment, most certainly the VA is doing suicide prevention in a very assertive / aggressive manner. And many, many, many lives have been saved. The VA's program is called SAVE, so SAVE, and SAVE is an acronym that suggests recognize the signs of suicidal thinking, ask questions, validate the person's experience, and encourage treatment and expedite getting help. SAVE. We'll go through these step by step. So while there are a number of warning signs and symptoms, some of the signs of suicidality are obvious but not others. And sometimes the signs or symptoms do not mean that the person is suicidal. What we are trying to teach everyone is to get past the stigma of asking certain questions, because the worst thing that could happen is that you might look silly. And I would take looking silly any single day, as long as I know that the person I was speaking with walked away safe. So it never harms anyone to ask them the questions about what you think might be going on, and to have them negate that for you. Some of the signs and symptoms are very, very obvious, and I know that a lot of the suicide prevention work has listed these signs and symptoms in the context of youth suicide, but the same signs and symptoms apply to veterans also. Threatening to hurt or kill yourself, looking for ways to kill yourself, hoarding pills, collecting weapons, you know, talking or writing about death. I found that one to be very, very applicable to young people who might be using death as a theme in their poetry. If you're a teacher and you come across poems like that, sit down, take the child aside and ask them, you know, what makes them write poems like that. Expressions of hopelessness are incredibly important to explore further, because whenever any context is difficult, probably the one factor that tips a person over the edge is hopelessness, when they believe that nothing will change. Rage and anger, you know, sad to say, but it's very true, that uncontrolled rage and anger can sometimes become self-directed, and that leads to a suicide attempt. There have been occasions where suicide deaths have been related to seeking revenge. I'm not going to kill you, but I'm going to kill myself. And that will show you, you know, in the context of interpersonal difficulties within the family, sometimes seeking revenge is the attribution behind a suicide act. Another sign is acting reckless or increased spirituality, or decreased spirituality. You suddenly start going to church more than ever before, or you start questioning your belief in God. Difficulty sleeping or sleeping all the time, And then the one very, very visible sign is giving away all your possessions. For elderly people in the same context is putting your affairs in order. You know, if that is done with a sense of urgency and as if the time is limited, I would recommend highly that people question the individual about that. Increased use of alcohol and drugs, you know, and we all know about the dramatic changes in mood, the agitation, no reason for living, and no sense of purpose in life. I'm sorry, I've jumped across 2 slides and hopped over these bullet points. So I don't know if you realize this, but I'm not a linear talker. I tend to be somewhat recursive, and I hope you can bear with me. So the American Association of Suicidology has a very good acronym here that summarizes all of these risk factors, and these are immediate risk factors. Of the above, I'm repeating myself, hopelessness is what I think is very, very important to explore because it is a marker for lethality of suicidal intent. You know, if you were comparing various episodes of a person expressing suicidal thoughts, and on this one occasion, you really tap into them feeling completely hopeless about whatever they're dealing with, you should tell yourself that the suicidal intent this time is greater. And that is what you should talk to them more about. For clinicians, it's important whenever patients come to us with stress in their lives, just ask them, how hopeless is the situation? Ask the question, and the most difficult question of all, but the most important question of all is, are you thinking of killing yourself? Are you thinking of killing yourself? And that question should be asked directly, not in a roundabout fashion. You can ask roundabout questions to lead up to this question, but the roundabout questions are not a substitute for this question, because only this one will open the door to the individual saying, yes, I am, or no, I'm not, and giving you more opportunities to intervene. So how do you ask that question? Firstly, you ask a question after you have enough information that makes you reasonably believe that the person might be considering death as an option. Reasonably. You don't have to be convinced, but you're going in that direction with your hypothesis as a possibility. Do ask the question in a way that's natural and flows with conversation, so you don't pop it out of the blue. But don't ask the question in a way to suggest to the individual that you want the answer to be a no, because if that's what you convey to them, that's the answer that they're going to give you. So these are some things for you to consider, and I'm going to just not even go through the list here, but the key element for all of these is that we need to show to our, to whoever we are dealing with here, whether it's family members, friends, or patients and clients, that we can accept that information calmly, and that we're open to that possibility. And, you know, many times patients will say, what are you going to do if I tell you that I'm suicidal? But even then you have to stay calm, and you have to convince them that whatever you're doing is in their best interest, and that all that you're trying to do is keep them safe so that they give time a chance to work things out on their behalf. So the bottom line principle, again, is all that we're doing as suicide prevention folks is buying time. Validate a person's experience. Don't come across as judgmental. Don't suggest to them that it's wrong of them to think the way they're thinking, because that is the way they're thinking. You know, our patients, friends, and loved ones want to protect us as much as we want to protect them. And the way they do that is that they don't share with us their deepest thoughts. unless they believe that we can tolerate those facts. And we all do that in our lives too. We pick and choose the people that we go and share, you know, deep, meaningful information with. We don't go and talk to just anybody about it. So that's the context of suicidal individuals as well. And then coming to the E of SAVE, we are encouraging, I'm going to really go quickly through the next two slides. We're encouraging treatment and expediting the referral process. But the only situation that one needs to be concerned about is with the uncooperative people. And this is a VA training, so I want to reference that, you know, veterans have been sensitized to a context of violence. So this is particularly relevant to veterans. But it also suggests that within the community setting as well, one has to use a slightly different approach with people who are not cooperating with your efforts to intervene. And for them, what you have to do is really call 911 as quickly as possible and bring in resources to help yourself, help that individual. Particularly if a person has a weapon in their hand or an object that they could use the weapon, step back and call for help. So you've got to, in the midst of everything, take care of yourself as much as you're trying to take care of the other. Moving on quickly, so this is about taking care of yourselves. I did take note of the response to the polling question of how many I hear because they know someone who died by or contemplated suicide. And this is where I come in with, you know, my statements today about how important it is for all of you, all of us, to take care of ourselves. Treat yourselves and your colleagues with the same compassion that you reserve for your patients and clients. Nothing is worse for a professional who is blaming himself or herself than to have colleagues withdraw in silence. This is done supposedly out of respect, particularly in working situations. But my bias, and I'm taking ownership for this, often it is out of self-protection. And it's an interesting type of self-protection. For most people, the question becomes, what do you say in a situation such as this? What do you say? What do you tell that person? Particularly when a patient has died by suicide. How about something as simple as, I'm deeply sorry for your loss? I know that we want to allow some questions here, and there are a few other slides, but I'm going to skip over, maybe I skipped over the next one, and I want to just quickly talk about safety plans and safety planning, and essentially refer you all, you know. So the consensus now in suicide prevention is that no suicide contracts don't work, you know. And most suicidal individuals who go to the ED for help do not follow through with treatment. So safety planning is something that originated on the East Coast, and it was developed by Barbara Stanley and Greg Brown. Is an intervention that you do with somebody that you think might be suicidal or even engaging in other types of high-risk behavior. I'm on to slide 45 here. So what is a safety plan? It's a prioritized list of coping strategies and resources for use during a suicidal crisis. But this prioritized list is something that you develop together with the individual. And it doesn't have to be in a clinical setting, honestly. It can be anybody with anybody. And it is a written document, and you write down in the patient, client's, or your family member's own words the responses to a few questions. And it's important to use the individual's own words because that is how their self-talk goes. You know, so it's not something that you say to them, it is what you get them to say for themselves. And that, through this process, you get them to make a commitment to treatment and reaching out for other help and support. I'm going to skip over this one, go to the next one. And these are the 6 steps of safety planning. Recognizing the warning signs, so you're asking the patient, how would you know that your risk is going up? And you write down what they say to you. I'm not in a position to really teach you safety planning right now, but encourage you to go and seek out the resources that are available. What are the coping strategies that you use to help you deal with your stress? That's number 2. Number 3 is, who can you go and socialize with if you're feeling depressed, blue, or agitated? Number 4 is, who are the family members or friends that could help you to resolve this crisis? So again, going back to the theory of social networks, that is what you're trying to create for this individual. When the first 4 don't work, then you put down the names of mental health professionals that this individual is connected with or could get connected to, including the suicide prevention hotline. And the last one is talking to them about lethal means. You know, do you have guns in your house? Do you have a lot of medication piled up in your house? What can we do to encourage you to put this away in a safe place? So that's the reference for safety planning, and I encourage you again to find this reference. If nothing else, call the VA and ask them to help you get a copy of the safety plan. All right, we have a few minutes for questions and answers or comments here. Kara, are you going to take over?
Yes.
Hello?
Thank you so much. That was such a wonderful presentation, and I think you really gave a great outline about the problem and the scope of the problem and how big it is, and some actual tips that we can all use in our practices. I did get a few questions along the way that I'd love for you to spend a few minutes to answer if possible. Someone responded to the reasons people hang on to some of those beliefs. They said denial. They thought denial was probably a reason. And then somebody said, I think, I had a question with the statement, I think that the belief of clinicians that a patient will complete a suicide and nothing they can do speaks to those clients who are impulsive. What prevention strategies do you recommend, for example, for someone who has no protective factors, is very impulsive, uses alcohol, and not taking their medication? Unfortunately, I think that people on the line and other clinicians have this kind of patient quite often. So what would be your advice around this?
You know, so the last one, I guess, is the most important one here, and it bears repeating because I didn't hear it and I'm not sure that other people have heard you. What do you do with a person who's not medication compliant, doesn't have access to resources, correct?
Yes, does not have any protective factors, is very impulsive, uses alcohol and not taking their medication.
Yes. You know, I think that is truly a challenge for clinicians, and sometimes one has to assess it at a very basic level, which is, and we didn't talk about doing in-depth suicide risk assessments, but clinicians need to know that you do have the leverage that if this individual is going to harm themselves, you know, you can call in the forces to get them admitted. But in my experience, what is more difficult is not the admission, it is starting the conversation about the admission. And so sometimes having the individual bring other trusted parties with them, and the trusted parties, you know, we got to start thinking outside the box. It could be anyone, but what you're looking for is a buffer. We often limit ourselves to, you know, do you have family? And if the person says, I have no family, well, that's the end of it. Do you have friends? No friends, that's the end of it. But, you know, we continue to explore with them, is there any one person that would be willing for you to come in with you for a conversation with me, you know? And what you're trying to do is an intervention where you're building the trust between this individual and the other person that they bring, you know. It could be a pastor. It could be anyone that this individual in this moment feels a human connection to. The very slightest even, encourage them to bring them in. Sometimes we have to leave our zone of comfort and say, okay, if you can't bring them in here, would you be willing to let me go out there and meet with you and together with this person? You know, so exploring the resources is a more creative process, but even more so is, again, to go back to the ambivalence issue and look for reasons for living. And one of the statements that I find has worked for me, and I don't know if it will work for you or not, but it's to quite clearly say, you know, given everything that you shared with me, I want to know, what is it that's keeping you alive? Because a desire for dying would be quite understandable in a situation like this. So there is something that's keeping you alive. What is it? And that becomes a very, very interesting, meaningful, gratifying conversation. Because if they've been in such bad shape and they're still alive to come and talk to you, then something is keeping them alive. Are there other questions? Because if we just talk about this one, I don't know if there are others that need to be addressed.
Yeah, there are other. That's really helpful, and I think, you know, important to note that another intervention is really building those protective factors. So that's really helpful. I hope people found that helpful as well. Another question is, what suggestions do you have in treating a teen who is disclosing suicidal thoughts, but the parent's dismissive and not taking the ideation seriously?
So I have worked in situations like that before, and it has to do, so it's worked for me to always do a two-part intervention. Once I'm convinced that the teen is pretty, you know, the suicidal ideation is serious, and the struggle is ongoing, I ask for a meeting with the parents first. And I do some basic suicide education and talk about risk factors and talk about brain development in teens and how impulsive behavior is the biggest enemy, you know? And parents, you know, just like everybody else, are in denial because it's very scary to think that their teen might actually end up dying. So getting them to come and talk. It's never taken more than one conversation for me to get the parents to realize that they have to speak up. And then to bring the teen back, you've got to ask the teen, is it okay if I have your parents in here, and sit with the teen. But in the occasions when I've done it, I've not had to talk a whole lot. I just do the introduction, as in your child has something to tell you. And from that point on, it becomes a very nice conversation between the parents and the teen. Does that make sense?
Yes, that sounds very helpful. And I'm aware that it's 1 o'clock and that our time is up. So I wanted to just tell everybody that Dr. Jha has been very kind and has said that you can contact her if you have further questions or concerns. Here is her information. Can you pass me the ball, Aruna, so that people can see my slide?
Yes, I'll pass you the ball now. It's with you. It's with you now.
That's me. Thank you so much. So this is her contact information, and she's been so kind to say that you can email her for further questions or concerns. So we're going to wrap up. Thank you so much, Aruna Jha, for presenting today, all of your and sharing your expertise with us. It has been really, really helpful and a wonderful webinar. I thank you so much. I want to share our upcoming events. Assessment of substance use among adolescent clients, and our presenter Julie Gutowski will be presenting on September 18th from 12 to 1 is our next webinar. Here are some resources we've also found, and again, these slides will be posted on our website at www.ctacny.com. So thanks again, Dr. Jha, and thank you everyone for participating with us today, and we'll see you soon. Have a great day.
Thank you for listening in, everybody, and for doing the work that you do. Thanks much.
Thank you. Bye-bye, everyone.